Thank you very much. Good morning, Mr. Chair. As my friends in East Africa say, all protocol is observed. My name is Pape Gaye, and I have the honor and privilege to be giving the keynote speech on this very important meeting. You will notice in my presentation that I will try to focus on the important role of the health workers, because that's the subject that my organization focuses on. I would like to also make a case for how the international scene and the international community is experiencing a lot of changes in trend, which in my opinion favors South-to-South collaboration. And in the last part of my presentation, I will try to talk about a few cases of very successful practices that we can adopt for more South-to-South collaboration. So the case for universal access to family planning and reproductive health services. As we all know, family planning and reproductive health is always one of the most challenging aspects of maternal and child health interventions, making universal access an aggressive but critical goal. But if each of us suspends our own judgments and assumptions and considers instead that the key to the issues lies in the recognition that the reproductive health decisions, including family planning, belongs to the individuals. We as advocates working together to create a better world must agree that this is the basic right of every woman, man, parent, to make those decisions with full education of their options and full access to high-quality services and supplies for what they may choose. In fact, it's quite simple. At the London ICPD meeting in 1994, like it's been said by Madam Vice Minister of the Gambia, my Vice President of the Gambia a few minutes ago, and many before that, many other meetings, our dear colleagues Steve Sinding and the global RH community debated the issues of adding a 9th MDG to the universal access for reproductive health services. The consensus was that our community should convince governments that the UN that many of the MDGs will not be achieved without achieving the Cairo goal first. This debate has continued with world leaders in endless consultations, meetings, and roundtables with little change. We know that family planning and reproductive health are intricately linked to health, population and development, poverty alleviation, economic growth, security, prosperity, and other engines of progress in an increasingly interconnected world. The challenges before us are not small, and in many cases have not changed over the last 30 years. Cultural and socioeconomic factors, inadequate resources, political opposition or political weakness, since even when government leaders are supporting family planning and reproductive health, there are many cases where other political factors prohibit bold action and agenda for support. We also know that in many cases, policy environments fall short. However, and despite that, every single day, almost 800 women die in pregnancy and childbirth. Every 2 minutes, the loss of a mother shatters a family and threatens the well-being of surviving children. Evidence shows that infants whose mothers die are more likely to die before reaching their second birthday. We also know that for every woman who dies, 20 or more experience serious complications. Of the hundreds of thousands of women who die during pregnancy or childbirth each year, 90% live in Africa and Asia. Yet, the MDG indicators are lukewarm, almost silent on assessing the impact of reproductive health or lack thereof on maternal mortality. It is imperative that we call for the restoration of reproductive health services to the next development framework, and the opportunity to do that lies in achieving universal access. There is a need for a global coalition of positive and proactive voices in support of this effort. As these pictures are showing, I would like to talk a little bit about the role of health workers and the human resources crisis. Because as long as we continue to operate in a climate of human resources crisis, our progress will be slow. And here are the facts. In 2006, the WHO identified and declared 27 countries in a state of HRH crisis. These are countries that do not meet the minimum criteria of 2.5 health workers per 1,000 inhabitants. Today, all the 27 countries remain in crisis. This is not acceptable. We also know, unfortunately, that 1 billion people on this planet will never see a health worker in their entire life. 1 billion. That's 1/7 of our population. That is not acceptable. At Intra-Health, my organization, we believe that health workers must be present, ready, connected, and safe. They must be ready, meaning they must be present, meaning they need to be where they are needed the most. We cannot continue to have situations where the majority of our health workers are concentrated in urban centers and our rural populations continue to suffer. They need to be ready, meaning we need to equip them with the knowledge and skills that they need to do the job. They need to be connected. They need to be connected to the communities they serve. They need to be connected digitally, because in this era, in this time, if they are not digitally connected, they will not take advantage of their full potential, and they need to be safe. In this world, we are losing too many health workers in armed conflict situation. We already have a crisis, so we cannot afford to lose them. They are not safe because they continue to work in poor environment and are exposed to the disease that they try to prevent. So we need to make sure that these health workers are present, ready, connected, and safe. We know that community health workers, frontline health workers, provide the critical link to health service delivery and have more opportunity to directly affect health outcomes and life choices for the people they serve than in any other area of the health system. Bangladesh, our dear host, is a great example. India have very progressive frontline health workers and link workers, which I know we're going to be hearing from my colleagues in a little while. We know that rural and urban areas are not without challenges, but peri-urban, rural, and remote areas are extremely vulnerable with limited or no access to physicians and facilities. Community health workers will be the only accessible providers for much of the world's population. We know that these health workers will provide care across all physical and mental health areas, including counseling and information, and must be trained and supported to ensure the quality of care. They are trusted members of communities they serve, and this is an enormous opportunity for us working toward universal access to family planning and reproductive health. I'd like to consider this data generated by our Capacity Plus project, which is the US government's flagship program and investment, and the largest investment in human resources for health. A selection of countries identified by the UN as having slow fertility declines and the projected rate of population growth for each of them. Notice countries like Guinea, Mali, Niger, Somalia, which still have a contraceptive prevalence for modern methods in the single digits. You will agree that in this age, this is not acceptable. And the unmet need for family planning is also high in these and many other countries. The combination is in fact deadly, and we can do better. So if we use these numbers and project the population, the amount of health workers we will need to adequately care for the populations are staggering. And in countries who are far from meeting the minimum requirements of the WHO standards of 2.5 health workers, this is going to be a challenge. To be clear, this is basic and sometimes inadequate health services. Experts at WHO and others across all sectors have evaluated these numbers and proposed frameworks and assessment tools to identify the needs of each unique health systems, including physicians, nurses, community health workers, and now the social workforce and other specialized areas. Each of these countries is among the 57 countries in crisis. Let me speak now to the changing landscape in international development, which in my opinion gives us an opportunity for increased South-to-South collaboration. What are we seeing today? Certainly, maybe driven by economic pressures, maybe driven by the financial crisis, maybe driven by populations in the donor countries that are reluctant to continue to provide their tax dollars for aid, maybe driven by the rise in the BRIC countries. We are maybe also driven by the very, very positive things we are beginning to see in Africa. There's more and more talk that maybe Africa's time has come. We have been experiencing innovations. We've been experiencing growth stronger than any other continent. So all of these factors may be contributing to some of the trends we are seeing in international development. There is clearly shifting roles of the donor community, including donor and recipient shift. We are seeing more pressure for social accountability and increased role of civil society. We are seeing US government and other donors talk about some principles from the Paris declarations, but we need to move from rhetoric and these principles into action. There's a lot more conversations about women and girls, about gender equality, about country ownership, about health systems, about leveraging partnerships with private sector and multilateral organizations, about integrations, and about increased learning and accountability. We are putting pressure on ourselves to measure better and to measure better what we do. And we want to accelerate results with research and innovation. We are seeing major paradigm shifts that affects us. There is definitely a global shift to leadership driven by recipient countries, creating opportunities for country-by-country tailored approach by the people who know them best, favorable policy environments, and truly sustainable models that extend into every sector of government infrastructure and lead to lasting economic growth. The changing role of women, user-centered decision-making, individual rights, and choices. In this context, what are the opportunities for universal access to family planning and reproductive health? There is clearly a global urgency by the ICPD, +5, +10, the MDG, the looming 2015 as it approaches. So the case for contraceptives. Recently, the Guttmacher Institute and UNFPA issued a report in June that discusses the cost benefits of contraceptives. In this report, data estimates that 222 million women worldwide have an unmet need for modern contraceptive methods. We know that unmet need, in fact, is not sufficient. As Jan Askew in this room told us last night, we also need to think about the problems with people with met need. In fact, an official UN report on progress toward the MDG recently, and I quote, "Filling unmet needs for modern contraceptives could result in a 27% drop in maternal death each year by reducing the annual number of unintended pregnancies from 75 million to 22 million. Meaning we need to not only pay very, very close attention to unmet need, but even when needs are met, we still have our work cut out for us. So this number has decreased slightly since 2008, but increased in some other sub-regions, including the 69 poorest countries. Can review these slides a little bit. So 22 million, this is what would happen if, in fact, we were able to satisfy these needs. Then unintended pregnancy should decline by 2/3, from 80 million to 26 million. We also know that there would be 26 million fewer abortions. We also know that there would be 21 million fewer unplanned births, and it's estimated 7 million fewer miscarriages. Pregnancy-related death would drop by 79 million. We also know that there would be 1.1 million fewer infant deaths. So to reach these 22 million women, we need to change our approach. Renewed commitment by parliamentarians worldwide to meet these goals is needed. And we have some successes to celebrate. The case of Kenya, where the government has enshrined the rights of individuals to quality reproductive health, family planning care, services, and supplies in the constitutions with an annual 2012-2013 budget of 6.6 million. At the London summit in July, I heard President Museveni challenge us as leaders, especially government officials from developing countries, to dedicate themselves to addressing reproductive health needs and called on them to empower women in all aspects. President Museveni recognized that women do not only give birth, but are the backbone of the economies of the developing world. Your commitment is even more critical now when we must create favorable national policy environments for things that we know work, such like task shifting. I salute Zambia's commitment to remove policy barriers to task shifting and training and supporting health workers for new roles. Looking beyond 2015, Rio Sustainable Development Goals, inclusion of FPRH in the next development framework. We have a lot going for us. We know Mary Robinson and many of the human rights advocates have now reached a consensus on the human rights-based approach. We now have new players, the private sector, private foundations, new and old social entrepreneurship. We need to be engaging our young people. This generation of young people demand to be involved in their own lives and improving the lives of others. They operate with a moral imperative that is translated to action and ideas with the stamina that is signature of their generation. Boisterous, bold, fearless, forever seeking possibilities and solutions to every barrier that could appear. As Stephen Sinding said, we must shift our mentality to thinking of engaging young people to become the source of the ideas and services that enable them to enjoy healthy and responsible lives. We now have the new Family Planning 2020 movement. We can now start to talk from Cairo to Ouagadougou with the new French West Africa Ouagadougou movement, to the International Family Planning in Dakar, the Rio +20, the London Summit, and beyond. We are happy that Melinda Gates and the Bill and Melinda Gates Foundation has launched their no controversy approach to making family planning more available to communities that need them the most. We have momentum. The focus has changed. Recipient countries are in the driver's seat, and for the first time, this is not rhetoric. Monitoring and accountability and civil society are ready to engage in ways they have never been engaged before. Attention to full RH system, supply chain management, financial management of RH commodities, distribution, service delivery. The London Family Planning Summit generated, according to the post-summit literature, over $2.6 billion was pledged and commitments were made by 10 donor countries, 8 major foundations and corporations, 21 CSOs and NGOs, and 19 developing countries, including 9 PPD member countries across critical areas. Bangladesh committed to increasing monitoring of progress and access to services. 1/3 of MNCH centers will provide adolescent reproductive health services, partnerships, role of men. Ghana will make family planning free in the public sector and support private sector family planning services, expanding youth programs, national, multi-sectoral programs to increase demand and the role of men. India has committed to include family planning as a central element in universal coverage program, and with the addition and expanded choice methods, contraceptive distributions, from 2012 to 2020, India expects to reach 200 million couples. Increased CPR, this is Kenya, Kenya has pledged to increase CPR from 46% to 56% by 2015, and to increase funding and partnership for family planning commodities and services, scale up the voucher system for RH services, and increase youth engagement. Nigeria has promised to reach CPR of 36% by 2018, increase investment from 12 million to 45 million in 4 years with health worker training and partnership. Pakistan has promised to raise CPR to 55% by 2020, increase investment in family planning and contraceptive services to essential packages in 2 provinces, strengthen supply chain, train and increase communication to prioritize family planning for 100,000 health workers, partnerships, religious engagement, and the role of men. Senegal has pledged, and I believe has already done so, to double the national budget for management of FP program and increase their commodity budgets by 200%, include innovative approaches like injectable depot and 6-pillar strategy generated by demand, leveraging civil society, networks for advocacy, improved supply chain, etc. South Africa has pledged to strengthen family planning services with dual protection implementation of reform policy, investment, and health worker systems, and support for integrated services and targeting youth teams. Uganda has pledged for universal access to FP and reduction of unmet need from 40% to 10% by 2022, and increased national investment in procurement and distribution, integration of services, public-private partnership, innovation, social marketing, youth, health workforce support, and institutional capacity building. My last example, Zimbabwe has pledged to reduce national unmet need from 13% to 6.5%, and unmet needs of adolescent girls from 16.9% to 8.5% by 2020, to focus on women and girls, to increase national investment, to remove fees for FP services by 2013, to improve method mix, to target integration, public-private partnerships, civil society, advocacy, and health workers. I wanted to highlight these because I think it is high time that we keep putting the pressure for people to deliver on their commitment. These are commitments that were made, but they also pave the road for increased and better South-to-South collaboration, and I invite us to make sure we seize the opportunity. We know that the health workers will have a critical role in this. We know that the health worker, as being the entry point to the health system, will be the best catalyst we can have. As an ever-going champions of health worker, I invite you to invest on the health workers because they save lives. The case for South-to-South collaboration. I would like to cite just a couple of examples to finish. One is the very strategic strategy that Senegal is proposing, which is the 3D strategy, which I believe we're going to hear from Dr. Duff later on, which is we need to democratize, to demedicalize, and to decentralize family planning services as a strategy for reaching the most vulnerable communities. We have the recommendations for adoption in the Ouagadougou movement, and 11 countries in that movement have embraced that policy or some aspects of that policy. I'd like to cite the case of Rwanda, which, by the way, this is actually a map with, these are the PPD countries in blue, and these are the countries that have made commitments at the London summit. And that is the Senegal strategy, Let's democratize, let's demedicalize, and let's decentralize. The case of Rwanda is a very interesting case, and I think provides opportunity for South-to-South collaboration. It could be argued that they did everything right in this country. After the genocide, this tiny country in East Africa quickly became the darling of the international community. By investing in a national health system, a national investment in health and strategies and plan, then in the strategic plan for health. They have used technology since 2012, and there is investment in health workforce, including community health workers and task shifting to allow the community distribution, targeting both partners, engaging men, and promoting male circumcision to reduce HIV/AIDS, and to integrate RHFP in HIV/AIDS services, investing in education, universities, medical education, and other professional and secondary programs. By engaging youth and civil society and investing in national FP campaign, they have, in a very short few years, nearly doubled to 30% with the 2007 interim DHS, and nearly tripled to 27 modern contraceptive prevalence rate. The rise continues with the 2010 results of unmet need finally fell to 20% aid when it had been in high 30s and 40s the 8 years before. And with this success bring opportunities. The private sector and cutting-edge technologies wanting to be part of this change, donor investment has increased significantly in the national government and foundation, and there is frequent global press coverage exposing the favorable results to the world and sharing the lessons. In fact, it can be done. But the single most powerful factor in the success that Rwanda has enjoyed is political leadership. Notice Rwanda's statistics before the genocide and the dramatic change for the worse afterwards. Since then, President Kagame, ministers of health at the time, Jean Damascene, and now Agnes Binyagwa, have been unilaterally supportive of Rwanda's health as a link to economic growth and development. I would like to finish to talk about the opportunity of injectables with community health workers. Over the last 10 years, a number of countries have implemented programs at varying levels for community-based distribution of injectable contraceptives. Due to a strong evidence base produced by these pioneers, including Rwanda, Malawi, Madagascar, other countries are quickly considering the merits. Programs are yielding increased FP uptake in the region where they are implemented. Other indicators are also improving. In the case of Uganda, the government worked with USAID implementers to pilot a CBD program in 2 public districts and 2 private programs that built on best practices found by early adopters. The findings are confirmed, including reduction in TFR and maternal death, and increase all CPR, especially modern methods. Pilot supporters worked with WHO via technical consultation, resulting in new WHO guidelines that CHW can safely and feasibly provide in settings other than clinics, and the practice is accepted by communities. Lessons for scale include a focus on the health works, including training and support, sustainability, improved when the public and private sector work together, and resources can be maximized when the district leadership is engaged early. This has become fairly common in some countries in Asia and Latin America, and many African countries have now adopted the strategies, including Senegal, Togo, and Burkina Faso. I will end by this very personal quote. During a recent visit in Togo, I met with the Minister of Health himself, who told me about how excited he has become about the role of community health workers. Being a doctor himself and not very convinced, when he visited sites in a pilot project and saw what these community health workers can do, he had some new renewed engagement and promise that his government will continue support to these community health workers. Whereas they are not paid monthly salaries, the government of Togo now has decided to incentivize them on a yearly basis by creating a line item to support these community health workers. During that visit, I met a young woman named Dope. This is what she told me, quote, "My name is Dope Atakuma. I chose Depo-Provera. I'm 30 and I have 7 children. When our brothers from the community health workers came to us with the project, it was a godsend for me in particular, because when my last child was born, my husband asked me to do whatever was necessary to make sure I did not get pregnant again. Even though he is the one who gets me pregnant. So I told him that fortunately, that was exactly what our community health worker did. So he had no doubts about it at all. He told me to go and get family planning as soon as I could, so as not to miss the chance, particularly as it was free. So I went to Mama, my community health worker. Since then, my husband and I have been free. We no longer have to worry about another pregnancy. Now I can enjoy get-togethers, funerals, and so on. I think that some of our sisters are hesitating because they are ashamed. They worry that the community health worker will tell others what they say when they go to this appointment. I think they underestimate the role of these community health workers. I thank you for your attention, and I call for us to seize the opportunities beyond us to increase family planning and reproductive health and to increase South-to-South collaboration. I know we can do it. I thank you.